So our next speaker is J Devereaux, who many of you will know. He obtained his medical degree from McMaster University in 1994. After medical school, he completed a residency in internal medicine at Calgary and a residency in cardiology at Dalhousie, and then a PhD in clinical epidemiology at McMaster. He holds a Heart and Stroke Foundation of Ontario Career Cancer Award, and he's the head of cardiology and perioperative cardiovascular clinical program at the Uravinsky Hospital and Cancer Center. He's also the scientific leader of the Population Health Research Institute, and the focus of his clinical research is vascular complications around the time of surgery. He's undertaken a number of very large international randomized trials and observational studies addressing this issue, and he's published a huge number of papers, editorials, and book chapters, and he's going to talk about whether to cluster or not to cluster. PJ?
Thanks, Andy. So thanks very much for the opportunity to present here today. As many in the room, I do owe a lot to Dave and a lot of thanks. I think there's lots of chance things that happen in your life that have profound influences on what actually ends up happening to you. So I grew up in Cape Breton Island, and as Andy said, I ended up doing medical school here in Hamilton. And my goal was always to go back to Cape Breton Island and be an internist, and that was, to me, that was the most ideal thing that could happen in life. And so on day one of medical school, the sort of student tutor was so excited to tell me that my student, advisor was going to be Dave Sackett. And I think this is the first thing she said in the tutorial, and I remember being very struck that she was elated about this. And then I asked the unaskable question, who's he? And slightly horrified that I would ask this question, she then told me he is this extremely famous, influential clinical epidemiologist. And then based upon my mother's influence on me, I smiled politely and thought to myself, I got to get rid of this guy. After our tutorial, they took us to our homeroom, and there was a letter in my mailbox from Dave saying, call my secretary, we're going out to dinner tomorrow night, of which I thought this would be great. I'll have dinner, tell him, look, I need someone else. And anyways, long story short is that Dave would open my eyes to a whole lot of things that would influence me in big ways and would influence my career, and I'm really grateful for that. And I'm also very grateful that he and Barbara were very kind to my family in that. So as for many people, Dave, thanks for all the influence you've had. Now, I'm going to, though, challenge you in your delight about randomized trials. So I'll put up my conflicts. One of my conflicts is I do spend a lot of my time doing randomized control trials. But more importantly, I am a passionate believer that, in fact, randomization is, in general, the best tool to determine therapeutic effects. So I believe that, and you should keep that in mind. That'll be a bias towards what you're about to hear from me. Now, there's many views that have been published about randomized control trials. In the BMJ in 1998, they said that RCTs were the most important development in medicine this 20th century. The proper means to assess effectiveness of new remedies is uncontroversial. It's the gold standard is the randomized control trial. New England Journal of Medicine in 2000, RCT results considered evidence of the highest grade. Annals of Internal Medicine 2001, RCT is a very beautiful technique, and my favorite from James Lynn Library. It's a powerful, dynamic, sexy, authoritative stormtrooper. There is no doubt there's lots of us in this room drinking the Kool-Aid, and we believe this. I'm one of them, but I do want to say I have some real reservations about some of the roads that we're on here. I worry that we've created somewhat of a myth. I worry that in our zeal to turn people on to what is inevitably a powerful tool, that we've given the impression that it's somewhat magical, that randomization takes care of all evils, and in fact we can really be confident that randomization will in fact allow us in any form of randomization to get results which will approximate the truth. And that makes me very nervous, and that's why I do genuinely appreciate Don and others pushing us to think of new approaches, new thoughts. And also too, I just worry that at times people are taking randomization and using it in forms which is undermining the good name of randomization and I worry it's going to lead us into some troubles, and that's what I'm going to talk about. And I think, this issue that randomization data is always superior to observational data, I think there's times where that may not be true. So I'm going to talk briefly, and I want a lot of discussion on this whole issue of cluster RCTs. So I think as everyone in the room is aware, a cluster randomized controlled trial is a randomized trial where the randomization is a social unit or group rather than individuals. And they're then randomized to different interventions. The unit of randomization can be a small cluster, it could be a household, or it could be very large clusters, anything from a hospital to a city. The proposed reasons typically for undertaking cluster randomized controlled trials most commonly are put forward as the fear of contamination, which certainly at times can be very real, and also issues potentially of feasibility. My first concern about randomized cluster trials is the following. How many of you in this room have been involved in the conduct of a multi-center parallel group RCT? If you have, I want you to raise your hand. I want you to keep it up. So please raise your hands. Should be most people in this room. Okay, keep your hand up. Don't let it down. If you stratify your randomization by center, I want you to put your hand down. Okay, so remarkably, there's a couple who did not, in a multi-center trial, stratify the randomization by center. I put forward to you that, you can put your hand down now. I put forward to you that in my experience in interacting with people, the vast majority of multi-center randomized controlled trials will in fact stratify by center. In fact, I think it's the only universal thing that a lot of people actually do agree on, despite Don being the natural resistor here and outlier saying, no, we're not going to do this. But it raised the question then, why do we stratify by center? Why do we believe this is so important? Well, one of the things that I've been fortunate in, and many people in this room have been fortunate in, is training in many places around the country. One of the things I've been struck by in training in many places around the country is that I think there is no doubt that there is real variation in the type of patients that show up in certain hospitals. Having done my clerkship in Hamilton, where at that time when Stelco and Dofasco were the heart of our city, I was used to seeing men who smoked, who had coronary disease and COPD, and I went to Calgary, and my first rotation at the Foothills Hospital, I was seeing people with lupus. I remember thinking, like, this was a completely different world. So different patients show up in different centers. Further, is that there is no doubt that although there's lots of commonality of management, there is lots of center effects, and people do things differently across centers, and some of the things that they're doing differently may influence the outcome. And it is for these fundamental reasons that people stratify in their parallel group RCTs by center, because they don't want a center ending up with a dominance of their patients being in group A and another center being with a dominance of their patients in group B, because of the concerns of the patient population and the other interventions that may be going on that will influence care. Now, because in our cluster RCT we are randomizing by the center, the issue is we still have this problem that these unique issues exist at the center level. So the real issue is whether or not, in fact, statistics can overcome this problem for us. And I'm completely skeptical that statistics can simply overcome this problem in the traditional way that it's being used to say we can take care of the fact that there's different patients and there's all kinds of different practice patterns that are going on in these centers. And I put forward to you that if statistics really could do that for us, I'd be in 100% agreement with Don. We can get rid of the RCT completely. If statistics is that powerful that it can overcome all the various issues around management that happens at centers, patient populations at centers, I'm skeptical we need RCTs in the first place. Now, for the parallel group RCT, imagine that we're doing a 40-patient, high-quality randomized control trial. So everything we think that matters in terms of methodology is done correctly. We end up randomizing 20 patients to treatment A and 20 patients to placebo. Heart attack, myocardial infarction occurs in 1 patient assigned to treatment A and in 11 patients assigned to placebo. The relative risk reduction is a 91% reduction. Highly statistically significant. P-value is less than 0.01. If you're moderately to strongly convinced treatment A prevents MI, I want you to raise your hand. Okay, so 3 or 4 people. So majority of people are not moderately to strongly convinced that treatment A works. I think they're right. I think we should be incredibly skeptical about this result. This raises the second concern I have about cluster RCTs. The reality is most cluster RCTs have very few clusters. Now, when I talk about the 20 versus 20 patients, most people are concerned. They're cautious. They're not used to seeing randomized parallel group trials at 20 versus 20, so naturally it makes them skeptical. But because people are used to seeing cluster trials of 10 versus 10, published in reputable journals, they're less skeptical. That doesn't mean that that's necessarily the right approach, but I think that's essentially the background psychology that happens a lot. The consort statement of cluster RCTs, it recommends the following quote. It is recommended that the minimum number of clusters per arm to secure valid analyses should be at least 4. If I told you about a parallel group trial of 4 versus 4 patients, my gut instinct is that most people, no matter what I said, would never believe me. They're not used to seeing it, and their instinct tells them, how could we be confident that we really achieve balance of prognosis in 2 groups when we have 4 versus 4? Yet, and I deeply respect the people that do actually consort. We have consorts saying, we want to at least have this. So that's suggesting that at 4 versus 4, we should be potentially okay. Or 5 versus 5, we should be great, because we've now gone beyond this. I really worry that we've misled ourselves on this point. The concern about the number of clusters is an extension of the first concern about the center effect. To the extent that we have center effects happening, it's also going to be compounded by this issue that we have very few centers involved here. And the problem is that the center effect is completely confounded with the treatment allocation. So the separation of that is challenging when you have so few in terms of or what I believe should be our confidence in the underlying belief that there are effects or not a lack of effects in terms of what we see. In cluster RCTs with thousands of clusters and maybe potentially hundreds of clusters, this is likely a lot less of an issue. But the problem is the BMJ paper, which looked at identified published cluster RCTs between 2000 2008 in our leading medical journals, the median number of clusters in trials is actually 21. So it's, let's say, 10 versus 10. I think that, we're so far out of the range of where we need to be at. I just have great reservations about this tool, which I think is being lent a certain credibility because it's using a randomized approach. So, everyone needs to stand. We need some exercise. Everyone stand up. Stand up. You got to work for this lecture. Okay. Yes. I want you to imagine that you're conducting a parallel group RCT. A center indicates to you that they're going to randomize the patients, and then they're going to confirm eligibility, and then they're going to get consent. If the patient doesn't fulfill eligibility or consent, they then want you to remove the patient from the trial, and they'll grab the next one. This is a parallel group individual patient RCT. If you don't have a concern about this approach, I want you to remain standing. If you have a concern, you can sit down. Okay, so Don, you're sitting down. Okay, you can sit down. There's 3 people. I'm waiting. I feel I'm going to be crucified during the conversation afterwards, but I have profound reservations about this. The single methodological factor in terms of research of individual parallel group randomized control trials that has consistently shown up to suggest it introduces bias is lack of concealment. I know which group the patient's in, and now I'm going to decide whether I'm going to recruit them, I'm going to bring them in the trial. Why should we have any less concern within a cluster RCT? In my experience of doing RCTs, I think frequently we want to pretend the world's one way, which clearly your everyday life tells you it's completely not that way. My experience doing RCTs, it's profoundly simple to influence people whether or not they're going to go in a trial. If someone's a complete train wreck and I believe in the intervention and I happen to be assigned to the group that's control in my cluster RCT, and now I approach this patient as a train wreck, I don't think I'll have any difficulty convincing that patient this may not be the best choice for them. And it's not necessarily that it's a conscious act. I don't think people necessarily try to sabotage research, but the reality is I think we're fooling ourselves if we don't acknowledge the point that Don had said initially, is that we're incredibly biased towards our own beliefs. And at subconscious levels, that can influence us. And this is why consistently, people make a big deal about the issue of concealment in parallel group individual level RCTs. And I don't know why we're somehow thinking that all of a sudden it doesn't matter because we're doing cluster randomization, because randomization now all of a sudden at this level is magical and will take care of this problem for us. So my third concern about the randomized control trial is that a recent publication from Ottawa, statement on the ethical design and conduct of cluster RCTs, just published in BMJ. The bottom line is that the participants, according to this consensus document internationally, if you're doing a cluster RCT and there are participants in the RCT cluster, it needs consent. These individuals need consent. Now, how do they define a participant? Well, a participant is anyone for which, in fact, you are going to directly intervene on, or you're going to manipulate their environment, which will then potentially have an effect on them, or you're going to directly collect information and follow up from them, or you're going to collect information and follow up, and there is some potential through which people could figure out who that patient is. And I put forward to you that, for the most part, that's the vast majority of cluster RCTs. I'm not saying there's none that won't fall in that category, but for the most part, we're really saying that cluster RCTs require individual patient consent. However, they do put in a clause that research ethics committees may approve a waiver or alteration of consent, but there's requirements. The requirements are these. When research is not feasible without the waiver of consent, and the study intervention and data collection procedures pose no more than minimal risk. I'll put forward to you that it is extremely unlikely that you can't conduct a trial without getting consent. I'm not worried about the feasibility, I'm worried about the issue of the bias. I think that almost always you can pay money, spend time, do it. I don't think that that should be the actual target that we're looking at. The issue is, if we do it, are we likely to actually bias our results and actually undermine what we're trying to understand? And so I think the reality is, based on the statement, there's very few cluster RCTs that are likely going to be able to say, you know what, it's just completely infeasible to get consent. There may be some, but that's going to be a very rare case. You can almost always get a consent. It may be a pain, may cost you money, but I just worry that that's the wrong target. Studying the BMJ looked at 36 cluster RCTs published in top medical journals between 1997 and 2002. 30% had evidence of differential consent to recruitment across the clusters. So once again, if we're going to basically insist that it's unethical not to get consent, here's the concern that you end up seeing that can play out in the trials, is that across clusters you get differential consent rates happening, and I suspect part of what's influencing it, is difficult to imagine other things, is actually that people, they know which group patients are in, and it seems hard to believe that's not influencing people. This shows you the results of a bunch of trials that looked at hip protectors to prevent hip fractures. Now, the blue dots are showing you trials that were looking at hip protectors, and these were individual parallel group RCTs. The ones that are in pink are cluster randomized controlled trials. Now, as you can see, the cluster randomized controlled trials were on the side of suggesting that hip protectors were very beneficial, and in general they were all clustered together. There's not much of a distribution. Whereas what you see with the individual level RCTs, there sort of is a funnel shape, and in fact they were suggesting that in fact the hip protectors were not beneficial. Now, a couple of things, there may be many potential explanations why we see this signal, and it's a single example. It does not prove anything, but it does raise some potential worry that maybe some of the things I'm saying about cluster RCTs may be having impact on the reliability of signals. When I look at the cluster RCTs, some of the RCTs that were clustered had substantial differentials in consent rates between the control and the treatment groups. Also, too, in some of those trials, when they looked at the age distribution between the hip protector cluster versus those that were in control, substantial difference once again. So it does raise the possibility that once again these cluster effects, because people are unblinded and recruiting people after the fact, may end up influencing what that result is and may not be reliable. So it's one thing to say that we have problems. The real issue is we have problems in everything. Is there ways potentially to move forward and to think about this thing? I think the first thing is the acknowledgement that there is no doubt, and I don't want anyone in the group who is doing cluster RCTs and maybe doing a cluster RCT of 4 clusters, I'm not in any way trying to undermine the reality and challenges and the contribution that that makes. But I think we do have to acknowledge that because something is difficult, it doesn't earn a free pass. We should not accept lower standards, and we have to push ourselves to recognize the limitations in all of the designs we're using and find ways to overcome that. And I just worry at the moment that, from what I see in all the discussions with people, is that cluster is to a great extent getting a free pass, and it makes me concerned. That does not mean for a second the people doing the trials are not making contributions. It doesn't mean that it's difficult. I fully accept. I have enormous respect for anyone doing research because it is bloody difficult. So please don't take it that way. I do think that one potential big step forward is the cluster crossover. From the perspective of I raised real concern that centers are such a potential impact on outcome for a myriad of reasons, from patients to co-interventions to practice plans. If we do a cluster crossover, we actually overcome the actual center effect because the center is acting as its own control. So as Salim had alluded to earlier, Stuart Conley, Andrew Cron are doing a really fascinating cluster crossover trial where for a period of time, some clusters are initially randomized to just give one dose of antibiotics before an insertion of a pacemaker or a defibrillator. And then after a 6-month period, there's a washout period, and then the entire center flips over, and then everyone in this center now gets preoperative antibiotics. Antibiotics are infused into the area, and then antibiotics afterwards. That center acts as its own control. You remove the center effect. The one thing you have to be cautious with is that if there's variation across time in certain things, then you're going to want a lot of crossovers. You want to take that into account. But I do think that that is potentially a big step forward when possible, may not always be possible, to overcome the issue of the center variability and its potential implications to this. I do think that we need to really change our thinking about parallel, individual trials, but importantly also about cluster trials, because they're miles behind. At least I'm worried where parallel individual trials are in terms of number of patients, but clusters I'm profoundly worried. I think there's great fragility. I hope everyone will be here tomorrow. Mike Walsh is going to give a very important talk on the whole concept of fragility, and Mike's done some great work on this area. Mark Duffett, I think along with Dave and Lahana Tabani, is going to look at the issue of fragility within cluster RCTs and how small changes to the outcome in a cluster, how that potentially all of a sudden reverses or changes what the actual outcomes are. And to the extent that that happens, one might want to be a lot more cautious about their interpretation of this. But I just think we need to get in the mindset of we need a lot of clusters. And Salim spoke about the issue of the vitamin A story, which I think is actually an incredibly fascinating story. Slight alteration of what he said, the trial that was published in Lancet recently with vitamin A, it had 1 million children participate, it's true. But importantly, there was actually 72 clusters. And we're talking about total mortality of kids. So it's 36 versus 36 clusters. There's no doubt that that trial must have been, just a birthing process 20 times over. That was difficult to pull off. No dispute about that. I just put forward to you that there's a whole lot of things that influence the likelihood that kids will die beyond vitamin A in clusters when we have 36 versus 36. And there may be a whole host of reasons why, in fact, the result was seen that it was seen. And I just, once again, worry that essentially the unit of randomization is the cluster, and there's different ways of dealing with the analysis, but nonetheless, it still comes back to the issue that we have 36 units. The issue of consent is one that I think that we seriously have to tackle, and I think we need serious thought about. I think some people have put forward the issue of getting consent, other participants, before you actually do the randomization, and the George Institute and their group, they've done this in a couple of clusters. There's no doubt that that's a very, it's expensive, it takes a lot of time and energy to have that happen, but if you could get all the people to consent ahead of time and then randomize, that'd be great. It's slightly complicated that you got to explain, you could go to 1 or 2 groups and all this ahead of time, but that's one potential option. I'm not sure it'll be feasible to the masses, but that's possible. I think, though, a big issue we have to raise is the whole issue of why do we need consent ever? And sometimes when you raise things, it's so contrasting to the way that we see the world, the way we experience the world, the way we understand the world, that it's just an outright rejection of it. And I know that people think when you say, why do we need consent at all, that it's heresy. But I think it is a fundamental question to ask ourselves, why do we need consent? And I'll use an example. Most of the cluster randomized controlled trials, a lot of them are willing, the IRBs, to say, you can randomize the patients, so essentially the patient's going in the trial, like they're going to be exposed to whatever the intervention is. They accept they will be exposed. But then you're going to have to get consent at least afterwards, to collect their data and follow them up. Now, in the CRASH-2 trial, for those who aren't familiar with it, it was a trial of 18,000 patients who had acute head trauma, road traffic accidents. And they were randomized to tranexamic acid versus placebo. And Ian Roberts, who ran the trial, is a very bright guy. They obviously got waiver of consent for randomization in the sense that they can't get a consent from a patient who's unconscious with brain acute trauma. But initially, the ethics committees all wanted them to say, to keep the patient in the trial, though, you will have to get consent to use their data. What he was able to fundamentally argue, which I think is a very sound perspective, and he was able to get rid of the need for consent for the follow-up and allow them to keep all the patients randomized, was that it was essentially unethical not to follow the patients. In other words, if there was any possibility that, in fact, what they were about to expose the patients to may not be beneficial, to not actually follow the patients up to know whether or not what they did was worthwhile or not, that would be the fundamental unethical part. In other words, if we are willing to let investigators randomize people to be in a cluster A versus a cluster B, and there's any potential that, in fact, we may be exposing them to a harm or benefit, is it not the ethical thing that we owe it to them to actually be confident we know what the actual effect was and to follow these people up? And I think that, we really should be challenging the question of, do we need consent? And if in fact we're willing to study something in a cluster RCT that's so risky, well, maybe the question is, should we be doing cluster RCT in the first place? But if we're doing things that are in the conception of standards of care, why do we need to actually go this route? And once again, I realize that that will be challenging and many people will dismiss it outright, but I think because we've done something for one way for a very long time does not mean, in fact, that it is the right way, and I think we need to challenge ourselves on this. So that's all I have to say about cluster RCTs, and I'd be happy to take any questions.